That was an excellent talk. One of the things I've noticed is that different countries are not tending to take on the roles of, or take on the participation of community organisations in the same way that you are, and it really is exemplary. I was interested when you were first talking about the outreach program. I think you said you'd enrolled 1,788 people, 17% were positive and 99% were on treatment. Those sorts of figures are probably not being replicated in your other clinics. And I think one of the things that's really important in any presentation like this is to try and include in it what the cost savings are when you're task shifting, but also what the better yield is or the different yield, because so often your peers will be able to reach communities that traditional services can't. So I think it was a great talk, and I think it'd really benefit if you could put some hard dollars in there. How much does it cost to do it with your peers? What would it cost to do it in a clinic? Because the cost shifting that comes with task shifting is what's going to make other people consider doing it. Thank you.
Yeah, thank you very much, and I completely agree that we cannot just show the figures and assume that people will take on integrating this as part of the routine models in the country. And we are working this year to document the costing and also the cost utility, not only for the test and treat model, but also for the PrEP model as well. I didn't mention, but we have a parallel facility-based model for the test and treat and for the PrEP, which we collect the similar endpoints. So we use almost similar protocols so that we can compare things furthermore, and then to use all this information, not only the feasibility but the cost information as well to support integration to country program. Thank you.
Yes, Mark.
I agree with Lavinia. It was a great talk. You really addressed some important stuff that we don't hear much about, so it was really a great way to finish. Nitya, one comment I've heard around the conference this week and also previously is that there's not a lot of understanding yet about how we integrate all the new information we have about PrEP as a means of ending the epidemic. We've got a nice target, 90, 90, 90. Everyone knows what that means for treatment as prevention, but we don't really yet have an idea about what the target should be for PrEP and how to integrate that for both strategies to try and reduce HIV transmission. You're obviously doing that in some of these clinics. You're giving treatment as prevention, you're getting people on treatment in 2 weeks, and you're also offering PrEP to HIV negative people, presumably at high risk. Do we need more research in order to figure out how to do that, or we just need to develop better policy and get it like a figure for how to integrate PrEP with TASP?
I don't think that I can really answer or actually even made comments on those questions or concerns because I think that PrEP in Thailand and also in the region is still at its infancy stage. We still don't know that 54% of those people who we offered PrEP and accepted PrEP, how many of them will have what levels of adherence throughout the time. And then we are still exploring whether the risk criteria for PrEP proposed in international guidelines or US CDC guidelines will kind of be applicable for Thai settings. We still don't know. So I don't think that we can say what should be the target for PrEP access in the country. And MSM is just one population. We are not talking about transgender women that much. We are not talking about people who inject drug, although Thailand is the country where PrEP study happens in people who inject drugs, and also female sex workers are still beyond what is in the pilot programs or demonstration programs pipeline in the country. Still very far.
I don't know if Bob has a comment. I know you're in the audience, Bob, but anyway, I'll open it to the floor.
Microphone 3.
Okay, I'm from Vietnam. 4 years ago, we started online the outreach to MSM in Vietnam, but we fell with linkages from the HIV positive to care and treatment because, in Vietnam we have no specific clinic for MSM. Usually, for those who are the positive, often switch transfer to the community OPC. So, do you have any experience about that?
Yeah, we also discussed this in yesterday's afternoon session on the challenges in linking people who reach online or tested positive online to care. And I think that there are several opportunities that we can explore on. For example, under the online supervised HIV self-testing model that we are using, we will only be able to tell people that they have reactive test results, not the positive test result, because it's not yet confirmed. However, the sense of urgency when you provide post-test counseling will be in a way that you need to come immediately for immediate confirmation and then immediate ART initiation. So it's not like you have to get confirmation first or things like that. So I think that's one way. And the other way is to explore. We are now exploring the online referral system, which means that when you tested positive online, you have an option to register yourself into certain hospitals, and then you present to the hospital. And I think many newly diagnosed people, they feel that the first barrier for them to get access to care is that registration step, because you don't want to reinvent in all those stories one more time. But if you can just have this short initiation of online referral, that may also help. But I think there are many other options to be explored.
Okay, the final question, but please keep it short because we're running short of time.
Sorry, I just have one minor question. You know that you can send messages to the people that they access to your program, but using the messaging, does it mean that actually it will be easy for outsiders to identify the patients that reach, so it linked to the privacy issues? So do your program encrypt with any of the information?
Yes, with all the messages and all the online communications, I think that we all need to be very sensitive on which messages, which type of messages or words that you are going to provide to the clients, and that can be seen by other people as well. So this we work with the community people themselves to identify which types of words or samples of sentences that we should use. For example, to remind you for the next HIV testing visit, to remind you that you have to take ART, etc. So there's a way that we can work to know that this is like the coding message that we understand what that means, but not exactly the words, reminding you to take ART pills, or reminding you to take PrEP pills, or reminding you for HIV testing visits.
So let's thank Dr. Nithya again for her interesting presentation.